So we recently published, along with several colleagues, mostly throughout the U.S., on the combination of Carfilzomib and Venetoclax in patients with relapsed refractory myeloma. So that was the single-arm part of the study that is now ongoing as a randomized study between that combination and Carfilzomib and Dexamethasone alone. So in that study, we have different cohorts with different doses of Venetoclax up to 800 milligrams per meter square. 800 milligrams flat dose. And we explore different doses of Carfilzomib. The lower dose, 27 milligrams twice a week. The high dose, 56 milligrams per meter square twice a week. And there's once a week dosing with 70 milligrams per meter square once a week, which was really the cohort. They end up being expanded. And overall, the therapy was well tolerated. There was no new safety signal that occurred from the combination. The toxicities were pretty much what we expect for, Carfilzomib or Venetoclax alone. We did not see frequent or clinically significant tumor lysis syndrome, which has been a feature of Venetoclax in other diseases. And the activity was very high. It was close to 80% response rate and seems to be similar in patients with standard risk and high risk disease. This study was probably one of the last ones that did not enrich for 1114, and because that study was still being maturing as this study was ongoing. And if you look at those patients, they have a very high rate of response, and the patients with the longest responses on that trial are usually in patients with 1114, and they tolerate the therapy very well, particularly after the discontinuation of Carfilzomib at 18 months. One limitation of that study is that based on the time that it was accrued, there are very few patients who had received prior daratumumab therapy. And we know, those patients, once they become daratumumab refractory, the disease becomes daratumumab refractory, it's a harder disease to treat. So I find that regimen to be quite helpful on the patients that occasionally we see that who have not yet been exposed to Carfilzomib and are now refractory to CD38 monoclonal antibody, and who happen to have an 1114. And we can't emphasize enough the necessity to obtain that information at some point in the natural on the course of the myeloma. We always remind people that usually 1114 when present is present from the very beginning. So even if you have a FISH analysis that's several years old, that abnormality should not disappear. Because in those patients, Venetoclax can really transform and have clearly have a higher rate of response than just about anything else they could access at that point.